کلینیکای پین منیجمنت اینا رو چی میکنه، منیجمنت میکنه. ویدیو را از جای پین منیجمنت پیدا کنم، کلینیک پین منیجمنت. حالی که برای شما ببینم یک تعدادش هیچ ضرور نیست با شما وقت داشتید کنید، زیادتر سر دردهای عصبی یاد میکنن. کوره مام نمیفهمم، هیچ دکتر دیگه هم نمیفهمم، او را روان میکنن در پین منیجمنت که اونا معاینات مخصوص ما خودم در پین منیجمنت رفتیم، زمین دو آسمان زدن درد جای خود بده. خب به هر صورت از خاطر میره که ساختیم که از نقطه نظر پین منیجمنت که سب سپیشالتیست براتون یک واضح شود که چقدر یک موضوع مغلق است، مخصوصا از نظر اناتومی، نورولوژی، نورو اناتومی، که در کدام جای است که عصب است و در او امکان نیست که درد باشه و او عصب هم چون این را میفهمید کلشان مثل یک اینترنت واره تفاهمات دارن. ممکن است که عصب در یک نقطه موضوع باشه چون رابطه ازی مثل اینترنت واره، مثل یک جال واره دیگه است. ممکن است که در یک نقطه دیگه دردش در یک نقطه دیگه چی شود، احساس شود. اینا میگیم چیزایی که مقدر مهم نیست. از نظر اناتومی بسیار زیاد گپ زده، از نظر نورال پین بسیار گپ زده که او را کلش مثلا معاینات مختلف که تشخیص این بازی مغلق است که بازمو اعصاب پیدا میکنن و اعصاب باز استیروید و لوکال انستیک ضرب میکنن، باز اون ممکن است که تاثیر کنه، ممکن است که تاثیر نکنه.
Cycle.
باز همون جایی میکنیم
Of gynecology, neurology.
باز اثر چی میکنیم؟
Topics on pelvic pain covering anatomy, the nerve.
یک صدا کنید سر ما استادش میکنیم مثل ما خودمون باز
and then ranging specific conditions with peripheral nerve injuries, and then we're going to go towards endometriosis. And so there's information here and answer most of your questions. Pain of stands out with different subspecialties of gynecology, urology, just to name a few. So there's definitely some significant overlap. So just to go into
خوب ویدیو میشنه؟
بله استاد مش
pain knowledge. When we talk about pelvic pain, visceral pain, what is this? Usually it tends to be a very poorly localized pain. It's usually described as a vague discomfort, what we call motor and so you may have some reflex muscle twitching, or you may have dizziness related to these autonomic reflexes. And unlike somatic pain, it's triggered by stimuli like distension of bowel, contraction, ischemia, meaning lack of oxygen flow, or inflammation. So all of visceral pain, a very difficult condition. And on top of that, pain can refer to segment as the organ. And just to give you a better illustration of this, say you have pain that's being triggered in your heart, like as in a heart attack, and then you have those signals coming backward. Well, they're convergent neurons that are coming from a similar level. So you're getting like this referred pain. So it seems that even if your pain is primarily related to a pelvic organ, it may spread and it may be on the skin, and so that can make it a little bit more difficult to describe the pain. So what's special about these visceral nerves? Usually have very large receptive fields. And another characteristic about these nociceptors is that a lot of them are quiet. So they're hearing, they're not even signaling back. And so they actually don't often take. What happens over time is that they can continue to send these signals to your spinal cord and to your brain, central sensitization and kind of this nervous system, so perpetuating what initially started the process. Visceral afferent and efferent fibers are carried back through the residue in the diagram, and they also usually travel with the and parasympathetic nerves. And this field that really causes some confusion as to actually occurring and makes it difficult to describe, okay, where is this pelvic pain coming? This diagram illustration of all of the organs and how they can refer to other areas in your body as a heart, and it can left upper extremity. Talking about pelvis, you can see where the pain that the kidneys and the bladder can refer to. So this definitely makes treating and describing a little bit difficult. At all levels, from the spinal cord, you can have this concept of viscerosomatic. Different types of nerves are talking to each other to help this pain. An example of this would be if you have pain and you continued over radiation external chest pain. So you can see that visceral pain or chronic pelvic pain can be a little bit confusing because of the pain areas. And so if you have a chronic condition, then it becomes difficult to know what came first. Was it the skin? Was it the organ that actually hurt? And this is very important. And these are just some other examples of viscerosomatic and referred pain. If you continue to have urinary, you can sense that kind of in the generalized lower abdominal over time. And just to better illustrate this concept of viscerosomatic convergence, this is a typical track or path for your pain signal to travel. And anywhere along this pain signal, so anywhere here in the spinal cord or in your brainstem or even your thalamus or your cortex, there can be crosstalk of neurons, and so this perpetuation and this blow up of pain. And so all of these things lead to different types of pain signals and development of different reflexes. For example, you can develop autonomic spinal reflexes and activation of your sympathetic nervous system over time, which is separate from the nerves that are innervating your organs. And so, for example, if you have sympathetic overactivation, it can result in increased sweating, increased blood pressure. If you have a parasympathetic activation, alternatively, you can have hypotension, lower heart rate. You can have inhibition of your visceral motility, or it may be perceived as constipation by certain patients. So there's a broad spectrum of phenomenon that can happen even if the initial injury was just a single visceral organ. And again, you can see here just some basic anatomy, the A delta and C fibers. These are your pain fibers going into a region of your spinal cord. And you can see there's a lot of crosstalk. And the crosstalk occurs not just at the spinal cord level, but I'll show you some other pictures to illustrate how peripheral nerves also talk to each other and can perpetuate pain. There's also a special enteric nervous system, which is independent of all the nervous structures that I kind of talked to you about. And it also has some plasticity over time that can contribute to visceral hypersensitivity. So just along the lines of viscerosomatic convergence, the enteric nervous system can morph over time and also serve to perpetuate your pain. So, as the talk is referring to pelvic pain, I thought I would throw out some terminology there that you might hear in the literature when you're on the internet. So pelvic pain refers to anything related to the visceral or somatic nervous system structures from about your belly button level and below. And so with pelvic pain syndrome, there are many potential etiologies to this pelvic pain in this very general area, and it could be musculoskeletal, so spinal or nerve related. It could be gynecological, urological, gastrointestinal. And there's usually an absence of any other specific inflammation or pathology. And oftentimes, chronic pelvic pain is categorized in terms of the length or the duration of the condition, and usually has occurred for about 6 months or more. The pelvic floor, we're going to go into greater detail about, just to give you some familiarization of all of the structures so that some of the interventions that we can offer make sense. So starting at the bottom, you have your commonly known as your tailbone, and it's usually 4, and there's usually the end of the sacrum and the coccyx is coming out. Is to think about in different sacral segments. But one of the important functions of this coccyx is it's any of the what we call levator ani muscles and part of your gluteus muscles. And so specific function in stabilizing your pelvic floor and its levator muscle attachments, which I'll have a few more pictures to show. So normally with the coccyx, there is a normal angle of flexion, and there is usually a change or transient flexion. The person is changing position, for example, rising from the seated position. Typically, the neurologic in nature or related to a nerve, but otherwise it's related to the levators pulling on the coccyx, a constant tightness. Other things that have been described in the literature is a luxation or hypermobility. And previously, the solution that had been proposed would be to remove the coccyx. But the problem with that is that it can instability of the pelvic floor. Now, some of those muscles do not have anything to attach to. So long-term data in terms of that type of procedure has not really played out. Here's of photograph on the left is showing the coccyx inflection during sitting and then standing on the right side. Sometimes you can have some incidental findings of spiculizations or different bone growths on the coccyx. Whether or not that's directly related to pain hasn't necessarily played out completely. So aside from bony structures, there's a lot of ligaments, and you can see this dense array of ligaments. So, a lot of times we like to focus on just muscles, nerves, and bones, but it's important to also give some credit to the ligament pelvis structure together. And one of the very important ligaments that I'll talk about later is, as you can see here, this sacrotuberous ligament and sacrospinatus, because there are nerves sandwiched in between these two ligaments running in and out of the pelvis, which I'll have more illustrations of. So this is from behind, at the backside of a patient, and this is anteriorly at someone facing you. You can see again the sacrospinous and the sacrotuberous ligament, which I'll get into. One of the things that I just want to stress is there's a lot going this in terms of crosstalk, but also just in the sacral plexus itself. So a nerve that gets a lot of attention, for example, the pudendal nerve, isn't just you can see the sacrospinous and the sacrotuberous ligament, which I'll get into. One of the things that I I just want to stress is there's a lot going on in the pelvis in terms of crosstalk, but also just itself. So a nerve that gets a lot of attention, for example, the pudendal nerve, isn't just the only nerve.
ببینید چی ازی ایست که پیشتر براتون گفت یقینم فهمیدین که مابین از اینا چقدر تفاهمات است. اگه یک درد اینجاست این تمام نورون هم یک حجره عصبی رو میگه که از جایی که شروع میشه تا به جایی که ختم میشه. مثلا یک نورون از دماغ شروع میشه تا به پنجه پای. این مسئول یک وظیفه است. اینا چون مابین خود کامیونیکیشن دارن، کسی اینجا باشه ممکن است اینجا احساس شود. این از این خاطری رو بسیار زیاد مغلق میسازه. از او خاطر قدر شرط نیست ما میره نمیفهم، قدر شرط نیست که شما بفهمانیم، منتها از این قسمت هاش یک ذره تیر میشیم. اینا رو برای مسکولار اناتومی رو میگه. بیشتر نروس اناتومی رو گفته ما خواندیم، ما خودم هم یه اناتومی رو به این هیچ کس هم یه اناتومی رو غیر از که کسایی که چیستند همین pain management هستن که اونام
both females and males. The puborectalis, which I'll have a picture of, is basically a muscular sling around your rectum. And most of the time, to maintain continence, if this is your rectum, you have your puborectalis, and it's squeezing your rectum and also closed, and so that keeps you continent. And what the rectalis has to essentially relax and allow the rectum to become a tube so that a person can have a bowel movement. So some extremely important structures down there. One of the important ones also being the coccygeus muscle, which is involved in coccygeal flexion. And then there's some more superficial muscles, and I have some more pictures. But again, the ischiocavernosus, bulbospongiosis, those muscles in terms of maintaining erection and ejaculation, and also to control the end of your urine stream. So there are many important structures in the pelvic floor to give all of these structures credit. So just to show the diaphragm of the female, so now you're looking into the bowl of a female anatomy, and this is the front end of the pelvis. So you have here your urethra and your rectum. You can see that the puborectalis is a sling. I'll have another picture of this, but you can see all of muscles are basically goal and holding all of the organs in. And you can see what's commonly referred to as your levator ani muscles, including this iliococcygeus muscle, your coccygeus muscle as well. So this is kind of your final support, keeping everything in. And what happens in reality is that everything works in conjunction. So the top of your tube is actually your diaphragm, and you have your anterior abdominal muscles and your back muscles, and then you have your pelvic floor. So in order to have proper contraction of your starts with a fluid motion of engaging your core and your back muscles, and then fluid contraction of the pelvic floor. Sometimes what happens is people lose a little bit of awareness, or be it based on injury or just over time developing any laxity. And so what can happen is this fluid like back and cause issues with urination, issues with constipation, difficulty with bowel movements, or even pain over time. So here's a better picture of what the talus muscle does. So it's a sling right around the rectum area here. And what happens a lot of times in people with chronic pelvic pain is that it stays really tight. So people feeling constipated, feeling like they're having difficulty with bowel movements because it's part of the pelvic floor, it's getting contracted all of the time. And so some of the things that we can do, injecting Botox into that muscle to try to help relax the puborectalis and help with chronic pelvic dyssynergia. So here's the cartoon picture, again, just looking at the bottom of the pelvic floor. And this is the posterior side, this is the anterior side, so the urethra, the vagina, the bulbar spongiosis, superficial transverse perineum, and you can see kind of the layout here. And then more superficially, again, what I was talking about, this ischiocavernosus, bulbar spongiosis, your superficial and transverse perineum. So there are a lot of structures.
یه قسمت از این تیر کردیم براتون چی نیستک اینا حالا اینجا رو باز از اینجا
to nerve injuries. But starting with one of the common ones that are injured is this iliohypogastric nerve. And so it actually shares structures in the spinal cord with signals coming back from your ovary and your fallopian tube. So if you have a problem in your ovary or your fallopian tube, it can refer to this iliohypogastric nerve innervation or vice versa. It has a little bit of a motor function of your anterior abdominal wall, but the most important thing is that it innervates the groin area, the pubic symphysis, or the midline anterior region of the pelvis. Oftentimes, when men get hernia surgery, you can Rafi pain syndrome because these nerves have been inevitably injured, or scar may form over time that may lead to entrapment of these nerves. And the one that goes hand in hand with this is the ilio-inguinal nerve. And so, again, this innervates a very similar region to the iliohypogastric nerve, and I'll have a full layout or picture for you guys. But basically, any type of wide surgical incision, which I'll have a picture of, can cause some pulling on those abdominal. These nerves are exiting and traveling peripherally and can cause neuralgias, or trauma during needle bladder suspension is another potential mechanism of injury. But you can see here, this is a typical fan and steel incision that types of open gynecologic surgeries. And what happens is, in order to retract, sometimes you could have a retractor placed on the very edge here, but that's also the same location that the ilio-inguinal and the iliohypogastric nerves are traveling through the abdominal muscles peripherally. And so it can be another cause for the pelvic pain. And so we can different types of nerve. Ultrasound is a good friend of ours these days, and there's a lot of things that we can see. And you can see here the ilio-inguinal and the iliohypogastric nerves. We often block them together because it's very difficult to block one versus the other, given that this is probably only about a centimeter or two apart. But with a diagnostic block, or with use of steroids, or different modalities like pulse radiofrequency, neuromodulation, we can decrease the pain signals coming back from these nerves and get some pain relief that way. Another peripheral nerve that is commonly injured during or after surgery due to scarring is the genitofemoral nerve. And usually what we're interested in is the genital branch of this genitofemoral nerve. And so it innervates the skin of the mons and the labia majora in women, or the anterior scrotum in men. And there's a little triangle right in the middle of the groin region, which I can also show you. That's the femoral branch. But because this little nerve is running through the psoas muscle, it can definitely get injured commonly, for example, after you've had an appendectomy, and you can get some fibrosis or scarring around the genitofemoral nerve. So just to show you a picture, this is a cadaver dissection, but you can see how thin the genitofemoral nerve is and how it's running across the psoas muscle. So nerve injury doesn't manifest initially in entrapment for time, and definitely important to figure out what someone's surgical history has been, not just in the last 2 or 3 years, but even back a decade would be relevant for us. And here's a general area of innervation, skin innervation from these peripheral nerves that I've been talking about. So again, you've got your iliohypogastric, your ilio-inguinal nerve, and the genitofemoral nerve. And then there's also this lateral femoral QT, which does the outer thigh, and it's purely sensory. What I'd like to talk about is the pudendal nerve, because we were able to block the pudendal nerve techniques. And it is the main sensory innervation to the skin sensation of the pelvic floor. And to show you a picture, this yellow is the path of the pudendal nerve here, and it's exiting the greater sciatic foramen, and it's sandwiched between these two ligaments that we keep talking about, and then they travel peripherally and become three. So what are these three main branches? So there's a dorsal nerve that goes to the penis of the clitoris. There is a perineal branch between, obviously, the penis and the rectal area, and then the inferior rectal branch. And there is some motor function to the pudendal nerve, as I was alluding to earlier. It does control some of the function of your external urethral sphincter, as well as your anal sphincter. But blockade of the pudendal nerve alone doesn't necessarily result in incontinence if someone has intact internal sphincter function. But it's kind of a case-by-case basis that we use. And other nerves or other muscles that the pudendal nerve innervates are those more superficial muscle layers that I showed you earlier, like the bulbospongiosus, ischiocavernosus, deep and superficial perineal muscles. So those muscles were important for functions in maintaining erection, ejaculation, as well as for end-stream urination. So any problems with those types of motor functions could lead to a clue whether or not maybe there is some sort of pudendal nerve entrapment. And there are many reported causes of pudendal nerve injury related to labor and delivery, also specific types of surgeries like sacrospinous vaginal vault suspension, lasering to the vulva or the perineum, any type of squatting, repeated squatting, or straddle injuries, or extended motorcycle or bicycle riding. So a lot of things. And even there is connection with constipation. So chronic constipation can lead to continued irritation of this inferior rectal branch and can lead pudendal neuralgia over time and kind of spreading of the pain along the pelvic floor. Our neurosurgical colleagues have felt that there are four main areas of potential entrapment of the pudendal nerve. So at the level of the piriformis muscle that I showed you, the ischial spine, which is usually our target in terms of doing this nerve, at the canal, or any of the distal branches. So to give you a clue as to what are the potential surgeries that could cause the injury of this pudendal nerve is anterior sacrospinous vaginal vault suspension. And so what typically is that a strip be thrown in the vicinity of what we call this ischial spine. And unfortunately, sometimes nerves can get irritated over time due to scar formation or initially due to the stitch. And so it can lead to trauma of many different nerves: sciatic nerve, pudendal nerve, posterior femoral cutaneous nerve. So it's often helpful to do an immediate release of the nerve. But sometimes it's more subtle, and over time there may be an entrapment issue that develops related to surgery. So all of these things are relevant. There are some nerves that are harder to get to that can perpetuate pelvic pain even if we do some of these other blocks like the pudendal nerve block. And one of them is the levator ani nerve, so the main nerve that innervates the levators. And so there's actually a communication very commonly over half of the time with the pudendal nerve, and so that can help perpetuate pain and make it difficult to treat. And you can see here the dark green is your pudendal nerve, and it's running outside of the pelvic floor muscle, so below them. And then you have your levator ani nerve, which is on the organ side or the visceral side, and you can see that they are very, very commonly interconnected. Another nerve that communicates with the pudendal nerve is a perineal branch of the posterior femoral cutaneous nerve. And oftentimes, it may be a reason why we don't get complete lack of sensory impairment if we do a pudendal nerve block. And it's actually innervating more of the posterior lateral aspect of the scrotum or the labia majora, and also a portion of the penis and the clitoris. And so it's actually prone to injury very commonly as well, because this is the ischial tuberosity, commonly referred to as your sit bone, and probably if you palpated through your glutes, you could feel that ischial tuberosity. And so the perineal branch of the posterior femoral cutaneous nerve is running just right underneath there. So commonly, without a lot of subcutaneous tissue or muscle, that can get irritated over time as well. And just to show another picture, you have here the perineal branch traveling towards the scrotal area. Some of the newer imaging modalities that we use include MR neurography techniques. Prevalence ranging from 16 to 25%. Many times in terms of gynecologic causes, endometriosis is high on the list. Other things are adhesions after surgery. But unfortunately, there's no clear pathology in over a third of women, even after they go through diagnostic laparoscopy. So here is just a general list of some gynecologic causes of pelvic pain. Pelvic inflammatory disease relating to sexually transmitted diseases is actually a very common cause of pelvic pain if left untreated. Endometriosis, different pathologies related to the ovaries or as well as to the uterus, like uterine fibroids, adenomyosis. So to go with the most common diagnoses, endometriosis is basically any type of endometrial tissue outside of the uterus where it should not occur. Even though there's no clear etiology that's been pinned down or a cause for this condition, most of the time we think of retrograde menstrual flow. So rather than menstrual flow going through the uterus and vagina and exiting properly, that it's being tracked back through the fallopian tube and into the pelvis. But the shortcoming of this theory is that there are other sites that have been found of these endometrial implants, for example, in the lung, the skin, the eyes. And so another theory is that your lymphatic system and your vascular system can carry these implants in this tissue to these faraway sites. But unfortunately, there is no clear consensus at this time as to what exactly causes the endometriosis. So the typical patient that we see are younger women, so ages 25 to 35. They've usually never had children, usually involuntarily infertile, and they develop what we call secondary dysmenorrhea. So pain before, during menstrual cycles, but it doesn't usually happen immediately with the first menstrual cycle. It usually occurs several years after the start of menstruation. Oftentimes when a gynecologist goes in to look for these endometrial implants, they may not even visualize the tissue, as I showed you in this previous picture. However, endometriosis is definitively a histologic diagnosis requiring finding the endometrial implant looking at the microscope. One of the controversies is there are a number of women who have endometriosis but do not seem to have these painful symptoms. But typically, the patients that we see in the pain clinic symptoms, so deep pain during intercourse, pain with bowel movements, pain with menstrual cycles, and the typical cycle is 1 or 2 days before the onset of the menstrual cycle, the pain begins, and it will continue throughout the and so this will continue to occur over time. So there's many purported treatments, but most commonly with uncomplicated minor symptoms related to endometriosis, patients are likely to be put on some sort of oral contraceptive, oral analgesics, so non-steroidal anti-inflammatory drugs like ibuprofen or Tylenol. When things get a little bit more complicated with continued moderate pain, a lot of times other hormonal agents will be used like gonadotropin releasing hormone agonists. And these can be a little bit scary because they do cause a menopause-like symptoms, so not without any side effects. And then other things that our surgical colleagues will do with severe endometriosis requires laparoscopic surgery and excising the tissue, even doing hysterectomy or presacral neurectomy, so removing the nerve tissues that I just earlier. So that's where we come into play. We do have some modalities to offer, like a superior hypogastric plexus block through sacral spinal cord stimulation, or even physical therapy modalities, soft tissue mobilization, thermal modalities, and TENS. An interesting recent study that I found is this phase 2 placebo-controlled trial, which oftentimes people use for sleep. And in this study, they looked at melatonin at night versus a placebo, which is like a sugar pill, for 8 weeks. And patients seem to have really good reductions in their pain scores. My threshold is usually about 30%. A reduction of 30% is pretty good in my book. And reduce discomfort during cycles, improve sleep quality. So social treatment is relatively safe, that could, if not trialed previously. Picture sacral neurectomy. A long time ago, when this was done as a non-laparoscopic procedure, it's pretty, but again, luckily the surgical techniques continue to improve, and so this is a picture of removal of those hypogastric plexus laparoscopic port. So of pelvic pain can be things like pelvic congestion syndrome. So the analogy is like varicose veins on your leg. Varicose veins, your pelvic. And so what's typically seen is, again, this is going to be affected. The typical deep discomfort or pain during and then continued pain that lasts even a few hours afterwards. Sometimes gravity, like standing, walking, lifting heavy objects, can work. Certain syndrome, pelvic congestion syndrome, this is called where you're easing your vein between your artery and body. It is those same syndrome symptoms. So if it's not this, just a generalized not nutcracker syndrome, the treatments are focused treatments that are entrapment releasing agonists. Our vascular surgery can do pelvic vein embolism, and they're visualize the vessels. See, visualize them. This is actually a picture showing those dilated, the vascular here. Another common relates to a condition called vulvodynia. Rule out what inflammatory or nerve etiologies are not resistant under this category of which can be pain of the external genitalia. So your mom generally see outside, and it can be really provoked with or with pollen, or it can be spontaneous, to do with any type of pollen. And then there are more local, so dynia can actually be vestigial, so just the very vagina menorrha, and again it can be mixed. And so we can see right here, just structure, you can see the areas, all of these areas generally usually described as a chronic vulvar pain, burning, very wide age range that it can affect. It's immediately sexual experience, where it can occur later, or subset. It's one of the issues in vestibulodynia. Trying to figure, is this a set of patients, or are we a group of patients with many different down? And the vestibular, there are many things that are exacerbated, and treatment is a lot of symptomatic. We can place topical cream gels. A lot of patients will look for management of neuropathics or conditions, classes of medications, antidepressants, anticonvulsants. We borrow a lot of medications from different, but we use them to treat pain. And on the, our colleagues can do procedures like vestibulectomy. So actually resect painful. If someone has a pure vestibular, I actually try to reset tissue, and it seems to provide some causes that we more seen for painful bladder syndrome or bladder pain syndrome. So this condition related to inflammation, urinary, causing bladder differences to pass through, causing this pelvic pain. And it's the NIH had a very criteria or of different causes, specifically visualize pelvic ulcers on into the bladder, these glomerular ulcers. Well, this is this is now has evolved newer or interstitial syndrome, and so what now is more of a diagnosis, various conditions, sensation, pressure, just proceed urinary bladder has lower urinary returns, more than integration with our they make sure that have an viable cause. Time it has evolved more of a chronic pain syndrome like sensitization, and so to treat the patients in our pain clinic with the help of our, you can see highlighted common etiology, all of that bladder. You can see here of the normal and intact chem layer. So what people were these Hunter's lesions. The weird thing is that patients who understood the main symptoms are things like urinary, so going to urinate often, feeling like you have time in the middle of the night, and these symptoms severe that bathroom 15 minutes, a little bit better to but and again, so being condition very hard to function, to this complicated slide up UA. I wanted to point here as a first line, second line, and fourth line treatment. So we are intertwined with our I actually work with urology here, and his name is Payne. He's done a lot of research interstitial cystitis syndrome. So the combination of has been extreme multidisciplinary patients. Initial treatment modalities, so manipulation, pelvic floor physical, some Botox into the bladder that are being studied. So one of the things I like to tell patients is keep a food diary. There's definitely a lot of different spectrum of foods that can flare people's symptoms, or different positions like being seated for a long period of time. Another behavioral technique that we do is just voiding by the clock and making sure that, today I'm going to try, instead of going to the bathroom every 10 minutes, I'm just going to use a stopwatch. And I'm going to just try to limit myself to 15 minutes. 15 minutes, that's my window for not going to the bathroom, no matter how I feel. And sometimes that's kind of the approach that we need to take to help people get back to a normal daily life and be able to function. One of the studies done partly here at Stanford was to look at pelvic physical therapy and compare it to global therapeutic massage, what you get in a spa. One of the specific things that is included in this myofascial physical therapy is a generalized approach from the belly button all the way down to the knee anteriorly, as well as from the lower back all the way down to the back of the knee. So approaching globally the entire area, as well as some internal manual release if needed, and doing specific techniques that are helpful for painful bladder syndrome. So rather than doing those Kegel exercises, for example, one of the things that was encouraged was a double voiding exercise. So when a woman gets on the toilet to void, they would stay on the toilet and try to relax their pelvic floor. So this is the opposite of a Kegel exercise where you're trying to kind of contract and lift your pelvic floor. This is you're trying to relax. So these are opposing goals, and actually Kegel exercise can be very painful and counterproductive for people with interstitial cystitis. Other medications that you may run across with urology colleagues is Almeron. It's a compound that's like other blood thinners, but what it's thought to do is kind of rebuild the inner bladder wall. And this medication's been around for a really long time. Other medications are these H2, H1 antagonists. They are listed as second-line agents primarily because they're relatively safe, but not that much streamlined data in terms of their overall efficacy. Other things that our colleagues like to do in urology is placing different substances into the bladder. So lidocaine, heparin, another one being intravesical DMSO or dimethyl sulfoxide. With all these procedures, sometimes pain can flare transiently but pretty significantly with these bladder installations. And so this is where we come into play. We have a lot of different antineuropathics or nerve pain medications that we can help to manage the condition. One of which being studied most often is amitriptyline. And so people have found a pretty good improvement in symptoms at very modest doses. And this reflects all of the neuropathic pain literature. So generally, if you're trying to treat depression or stabilize mood with amitriptyline, this is a tricyclic antidepressant, you'd want to bump those doses up to about 100 or 150 milligrams a day. But with the treatment of pain, what we typically see is we don't need to get to those high doses, and we can still get some modest pain relief. And patients can tolerate these medications because they do have a number of side effects. And other studies have shown that amitriptyline in combination with other antineuropathics like gabapentin can be even more helpful. And this is another study that, again, just echoes the fact that even reaching a dose of about 50 milligrams a day could potentially be helpful. One of the things that I keep mentioning is neuromodulation. So we can actually place these, what we call spinal cord stimulator leads into the spine. And during testing, what we want is what we call a paresthesia, or a type of buzzing, tingling, pressure sensation that you would feel where you normally have pain. And so for a patient with pelvic pain, it would be in that generalized pelvic floor area. And so once we're pretty sure that our stimulation is covering that area, we can do a trial and see for about a week, are you really having a lot of pain relief? And if people feel that is the appropriate procedure, then we can do a more permanent implantation. But this is probably one of our most invasive therapies, and definitely not something that we would start with. You can see here some people have reported placing leads, what we call retrograde, or entering from the lumbar spine and actually covering the sacral area. But another approach to that, more commonly used, is going through the tailbone and actually placing these leads over the sacral area. And people can get really good relief of things like tailbone pain or just generalized pelvic pain. So there's definitely many, many more treatments coming down the pipeline, and definitely over the next several years, I'm sure that therapies will continue to improve. But the current state of the literature is just trying to tease apart who exactly are these interstitial cystitis patients, and basically phenotyping, trying to understand who they are. So definitely the definitions for IC have evolved over the last decade, and this has resulted in some difficulty in characterizing the efficacy of numerous treatments, but over time I think that we'll continue to have more potential therapies. And that's the end of my talk. The question was related to if your pain is spreading from the initial site of injury and flaring up other areas of pain, can that be reversed? And the answer is definitely yes. So our approach in the pain clinic is always to find the primary cause of the pain, and using different strategies. For example, medications can calm down a pain flare. So after being on something like amitriptyline or gabapentin for a period of time, it makes it easier for patients to localize their pain because their entire nervous system is not hyperactive or overexcited. And then we also can use our injections to help narrow down where the pain is coming from, and also to kind of hit that reset button. So doing different things like the superior hypogastric plexus block or doing peripheral nerve blocks can really help to block those pain signals from going back and bombarding the brain, and over time it can be reset. But it is true, over time, if it is a chronic phenomenon, those tracks become more difficult to reverse.
ویدیو حتما در کنفیوژنتان بسیار زیاد کرده. من از خاطر گفتم برای شما که چیست. ببینید که چقدر این موضوع مغلق است. اینا را شما کدام تبصره داشته باشین، کامنت داشته باشین. از او خاطر امپیریک تراپی که فقط آدم دوای درد بده، میبینین که قدر اسباب زیاد است یا بسیار مشکل است که مخصوصا در اینجا خود یا در اروپا مطرح در پین کلینیک روان میکنن که اونا اولویشن کنن و دیدی که هم گفتن که تقریبا 35 تا 40% ما علتش پیدا کرده نمیتونیم. اینا اگه کدام تبصری داشته باشین یا کدام موضوع رو گپ میزنین یا میگین که در دیگه هفته سر چی موضوعات گپ بزنیم. بخیلی گنگستان کردی ویدیو.
استاد گنگ خونه که مغلق بود، برالتش مغلق بود.
این دختر بسیار خوب چی کرد؟ لکچر داد، فوق‌العاده خوب از نظر پین منیجمنت.
استاد اینجا در یک قسمت اینترنتم چند دفعه قطع وصل شد. قسمت آخر رول سیمیتیدین و پیروکسین بود. نه استاد امور نفهمیدم.
صفحه جان روان کردیم این ویدیو رو براتون. امی پاورپوینتتان ویدیو را وقت دیده میتونین که او را در سلاید شو بانین. در غیر از او دیده نمیشه. هر ویدیو را که ما از اینجا از یوتیوب در اینجا داخل میکنیم وقتی که در سلاید شو بیا اونجا باز در سرش که کلیک کنین ویدیو دیده میشه.
بله. استاد یکم استاد گفتم بهتر است ما شما راجع به همین موضوع ولودونیا یکم زیاد بحث کنیم، چون واقعا پرابلم است. ما میبینیم مریضای ما زیاد انتیبیوتیک مصرف میکنن و زیاد تداوی میشن. امیر استاد ما خود کیور کار کردیم که بر ما گفتین چه قسمایی را میتونیم تشخیص کنیم او قسمت تریگرزون و موضوع را. گفتم اگر استاد امیر کم توضیح بدین دکتر صاحب دیگه اگر میفهمن یا بر ما یک تکرار شد فرش شویم تاسیس.
ما سوال تا نفهمیدم چی رو تشریح بتون زباده جا؟
ولودینیا استاد ولودینیا میزه که اسمون
ولودینیا رو براتون بگویم که چیست. باشین که ما براتون اگه شیر اسکرین کنم نیو شیر کنم اینی ولودینیا اتراسته که دکتر که علتش تا بال پورا معلوم نشده، مثل که در اینجا دکتر گفت که مخصوصا معمولا علت از این چیز دارد همین یک حادثه یک پرولیفریشن بسیار زیاد عصبی است، اعصاب است. همین نهایت خود نورونا بسیار زیاد یک پرولیفریشن میکنن. چرا میکنن؟ علت شو هم گفت که تا بال معلوم نشده. خب مریضا میان امرای درد سوزش محبل، اعراضشان چیست؟ میگه کالایم که در جانم میخورم مثل از یک کاغذ رگمال در جانم خورده باشه. اینا دسپرونیای همین اوتر دسپرونیا دارن، سوپرفیشل دسپرونیا دارن. معمولا اگه شما ایره چی کنین ببینین مریضا را که کمک کنه در اینی قسمت خود چی؟ اینی قسمت پرینیوم است، این اینجا احلیل است، این اینجا در بالایشون کلیتوریس است، این اینجا خود انس است. اینا از درد در معمولا در غیر از اون دیدیم که براتون گفت که در هر جای امکان داره که باشه، از ناحیه 3 بجه تا 9 بجه را شکایت میکنن. با این شما توسط کیو تپ تست، یگانه تست که آدم تشخیص کرده میتونه کیو تپ تست است. این کیو تپ را که برای کلچر آدم میگیره یا برای میکاپ مثلا خانم استفاده میکنن. فقط کیو تپ شما میگیرین، اینی تقریبا از 3 سانتی متر از اینجا، اون مثل که در اونجا براتون سلایدش نشان داد، اینی نایه کلش کیو تپ میگیرین، در اینجا یک کمک کنید فشار میتین. وقتی که فشار دادین مثل که دیروز ما شما کیو تپ گفتیم که دردهای سطحی را کیو تپ از درد عمیق تشخیص میده. مریض یک میگن اینجا بسیار سوزش کرد، هر چقدر که شما این طرف میایین اینمی نواحی تمام از سوزش میکنه. بعضا در طرف بالام است، تیپیکش هم است که از 3 بجه تا 9 بجه است. باز اینجا که ببینین یا ایست که هیچ درد نداره یا ایست که دردش بسیار زیاد کم میشه. اینی را به نام وستیبولایتس یاد میکنن. خوی موضوع التهابی نیستن که بولایتس یا وستیبولودینیا یاد میکنن، یعنی درد ناحیه وستیبول. میفهمین که قسمت وستیبول میگن. اینال ایرا وقتی که اگه شما محبل قشای مخاطیش رو بایوپسی کنین، در زیر خود چی محبل اینجا یک تعداد زیاد پرولیفریشن نورونا را آدم میبینه. از این خاطر است که دوایی که برای نرو پین میتن یا دوایی یا خود ترایسایکلیکا مثل الاویل یا ملرل، اینا بسیار تاثیر خوب دارن. وقتی که اگر شما تشخیص کردین از نظر مشاهده که کالاش در جانش میخوره، اینا باید اول خود حفظ و سیه محبله باید امضا کنن که محول همیش بشورن و پاک کنن اینا دیگه اینا بر از اینا امی فلورینیتد استروید که چیسته ترامسلینون است کنلاک برشان میتین مثل که پیشتر گفت اینه میره هر شو کنالوگ میسره خوب میماله تا که تقریبا جذب شود اینجا و این تاثیری زیتر آنی و فوری نیست تاثیرش معمولا قدم 2 ماه میگه تا که یک تاثیر کنه اینه نیست اگر این نشد اینه چند دیگه است اون دیگه گفت دستگیری ببینید اینی قسمت بشای مخاطی کچه میکرد خب یویسته که برای کاربون دی اکساید لیزر اینه میره که شدم 6 میلیمتر لیزر بکنه کلش تخییر بکنه ویپرویز میکنه یویسته که بستویتوی میکنه کلش توسط زیر یادم میکنه خب پرابلم از این نیست که هر قضایی جراحی که شما بکنید امکان نقصش پس ریکورنت بشه حدود 40 تا 50% است. بخاطر یک چیز بسیار فرستریتینگ است که آدم بسیار نتیجه نمی‌کنه. دیگر تداوی بسیار خوبی که ما نتیجه خوب گرفتیم ابراهیم جان شدم در چی جاغوری نتیجه خوب گرفتن اما تویست ما با بجان که برشن الابل داریم الابل مانده یک نوروپتیک است شما 25 میلیگرام رو شروع میکنید و یک 25 میلیگرام میدید و یا خود تاثیر میکنه ماه دومی به 5 میلیگرام میرسه ماه سوم در 75 میلیگرام میرسه اگر در 75 میلیگرام خود دیگر کرد این در 3 تا 4 ماه دوام میدید بعد از 3-4 ماه اساس بمیشن این اساس به تدریج کم میکنید تا اینکه بالکل قطع میکنیدش معمولا در حدود 60-70% نتیجه خوب میده ابراهیم جان شما گپ برمیشنین ما جان در اونجا هنوزم شما از استفاده میکنین بسیار یک چیز والا ما شما در اونجا بسیار زیاد دیدیم از این والویدین
استاد مریضاش زیاد هم هست استفاده میکنیم
بازدگه نمیم
میره پس باره بسیار خوشی میکشن
بسرشان این نیاز که در قدر سپیشلیتی در امریکا زیاد شده که به نام چی؟ والودینیا یک جمعیت است American Association of Valvodynia کسایی اسوسییشنی که تنها ریسرچ میکنن در سر درد محبت اندازه براتون فهمنده تونستم دکتر سیب زبیده جان
بله
استاد
استاد
میبخشید دوایی که شما گفتین چی است استاد؟
دوا این هر نورولپتیکه که بتین زیادتر ما خودم الویل ازش استفاده کنیم ملارل هم داده میتونیم الویل استفاده کنیم 25 میلی گرم اونم رقم
الول استاد نام جنریکش چی است؟
نام جنریکش باشین ما براتون ببینم به اینجا ابراهیم جان هستی امرای با خودت آمدی استفاده کردی کجاست رحیم جان گریخته ما براتون میبینم
نه هستم استاد هستم
و الویل نام جنریکش چی هستک؟
مجموع
امیترپتولین
شد
مثل کی گفتک نه پیشتر امیترپتولین هست چیست که
اناترپتالین
امیترپتولین لمبیترول هم هست دیگه اگه شما امیترپتولین باز ببینین الویل امیترپتولین اون دوزش باز در اینجا میگه که اونم است دیگه درش 10 20 15 75 تا 100 میلی گرم تابلتاش هست
درست
خوب است براتون کل چیزا رو مثلا تا اینه میبینین اینه خود اقسامش همراه رنگ تابلت و میلی گرم اینهاشون براتون اینجا نوشته میکنه و قیمتش هم میدونید
زنده باشه استاد. استاد میتونیم که به عوض از او پریگابالین گاباپنتین یارم بتیم کنم.
اونو دیدین دکتر برتن گفت تمام از یونیورسیتی سنفرد است در کالیفرنیا بسیار یونیورسیتی مشهور است.
زنده باشه.
خب برای دیگه هفته چی میخواین یا ما خودم تعیین کنم براتون؟
استاد گفتم در سر چی که میزنیم پینفول بلادر سندروم شما
سر اینترستیشل ستایتس خوینه شنیدین دیگه از ما که بسیار خوبتر براتون گپ زد.
موضوع دیگه
لسته ببینیم که چی اهمیت اولی داره براتون تعیین میکنم بر روز چهارشنبه. باز محبوب جان ابراهیم جان شما از اونجا باز برای من بگوین شما تقریبا کلی موضوع شنیدین برای من ایمیل کنین که چی میخواین بشنوین.
درست است ما باز ایمیل میکنم.
استاد یک موضوع میل انفرتیلیتی و استخبار بسیار زیاد مشکل داریم.
وقتا در موضوع میکروفون تا گفت ابراهیم جان انا میکروفون تو اکو میده. در موضوع انفرتیلیتی ما شما خواندیم. ما دکترای نسایی موضوع انفرتیلیتی مردا را تداوی نمیکنیم. یک چند کلمهش چند دفعه پیشتر براتون گفتم در مو کانتروورسی آف او بی جی واین هم یک دو سه تا سلاید در منجا بود. معلوم دار یکی از موضوعات ورکاپ تانم نیست که خود پارتنرش معاینه میکنین و هم یک معاینه نه اقلا 2 معاینه شوه و او را براتون پیشتر گفتم که 3 شو باید از اینترکورس خودداری کنن. در روز 4 اگه بهتر است که برن در مابین لابراتوار کلکشن کنن یا ایسته که اگه در خانه کلکشن میکنن در یک بوتل شرط نیست که معقم باشه بندازن و او را در زیر بغل خود ببرن برای از که در حرارت 37 درجه باشه. اینال فقط معاینه میکنن و میبینیم اون لیست از امریکن کالج هم براتون دادیم که کرایتریای نرمال و غیر نرمالش چی است. کسایی که ایزوسپرمی دارن آلیگوسپرمی دارن اونا تقریبا ایش تداوی نداره از نظر خود نورمال سکشوال انترکورس. اونایی که ایزوسپرمی دارن هیچ تداوی ندارن. متاسفانه او روزم براتون گفتم که در افغانستان اینا رو بسیار زیاد دوام میتن. به فکر من بسیار کار غلط و نامعقول است. آلیگوسپرمی هم به هر شکل اگه موتیلیتیش خراب باشه میگن که نیکوتین تو اینا نسوار و اینا در سر موبیلیتی چیستک مؤثر است. یک فیصدی ممکن است که موبیلیتی خوب شود. دیگه کسایی که آلیگوسپرمی دارن در یونیورسیتی باستان چندین سال پیش بسیار ریسرچ کردن که اینا رو تستوسترون دادن. تستوسترون خودش یک کانترسپشن میل است. تستوسترون برزنا دادن بس به قسم 1 ماه 2 ماه مثلا سپرم کانتشون 10 میلیون یا 20 میلیون بود یا 30 میلیون بود. به تمام مانا اسپرماتوژنزیس استاد میکنه. وقتی که استاد کرد اینا دفعتا تستوسترون قطع میکنه. یک ریباوند فنومن هست. مثل یک توپ شما میزنه پس ریباوند میکنه انعکاس میکنه. دیدن که تعداد اسپرمون بسیار خوب شد 80 90 و اینا مگر کوالیتیش هنوزم خراب بود. موتیلیتیش خراب بود مورفولوژیش خراب بود و که وقتی که دیدن که کنترل کردن همراه کسایی که اسپرم نرمال داشتن اصلا فیصدی پرگننسی در هیچ وقت بلند نرفت. پس بعد از اون فهمیدیم که نه دیگه کدام چیزی نیست. در افغانستان ما که دیدیم تا یک مقدار ریسرچ نکردیم که همه تو به صورت گروس دیدیم میگن که 40 تا 49% مردم انفرتیل هستن یا استریل هستن یا انفرتیل هستن و ما فکر میکنیم که از خاطر کلچرک است. خود ممپس از یک علت بسیار مهم تخریب سرطولی لایریک سل است. در افغانستان چون واکسین ممس وجود نداره، بسیار کم کس میکنن. از او خاطر است که تعداد انفرتیلیتی در پیش مردا بسیار بلند است. من اینمی برداشت خودم است. از اون خاطر ما امروز تمام کالگا و رفقا و دکترای خود همیش نظریه دادیم که اطفال بچه را کلشان باید متوجه باشین که واکسین ممپس یا اسکلچرک باید برشون بتین که در آینده برزنا چی پیدا نشه، انفرتیلیتی پیدا نشه. در غیر از اون معلوم داره اگر وضع بند باشه و اینا کلش مربوط به یورولوگ هستن. دیگه معلوم دار اسیستنت ریپروداکتیو تکنولوژی که میتونه که از مابین اپیدیدیمیس یک سپرم یک چند تا را بکشن و او را باز اکسی کنن که انتراسایتوپلازم سپرم انجکشن کنن. نتیجهش قدر خوب نیست. در غیر از او به صورت طبیعی امکان نداره. سوالتان جواب دادتان است؟
تشکر استاد. استاد بسیار خوب. زنده باشین استاد.
استاد ببخشید در افغانستان واکسین ممپس هست؟
باید باشه. با خود نیست یک مسئله واکسن برم جان در افغانستان؟ بخیر
استاد اینجا نداریم، نمیفهم کابله.
امرای سرخکان و امرای گلاو امرای چی باید باشه. نباشه از پاکستان بخواین.
واکسین های MMR میگن در بازار هست استاد. MMR
MMR خو روبلا است، میزل است و چیست کنی میزل ممس چیز میزل ممس روبلا است که جمع میزل است. اگر MMR باشه از اون برای اساسان که برای مخصوصا در جمع میزل مثلا باشه بخاطر که اون بسیار خوب نیست. مخصوصا مدارک دیگه در افغانستان بسیار زیاد است. سوال است
تشکر استاد. درست است. تشکر.
خداحافظ. زنده باشین.